All right, so I think we'll begin. Thank you so much, everyone, for joining us today. My name is Amy Sam. I am the Health Education Project Specialist at the Maxwell and Eleanor Blum Patient Family Learning Center at Mass General Hospital. Before we begin, I'd like to go over a few items with you all today. Please be aware that today's session is being recorded for educational purposes. If you're interested in viewing the recording of today's session, feel free to visit the Blum Center website at massgeneral.org/Blum-Center. Please note everyone is in listen-only mode. Everyone has been muted so that we can hear our guest speaker today. If you have any questions, please use the chat feature, which is located at the bottom of your screen. We'll have time for them at the end. Only the Blum Center staff and guest speaker will see your questions. Please do not share any personal medical information or questions in the chat box. If you have any personal medical question, please ask your doctor. So next, I would like to introduce you all to Dr. Megan Lockwood. Dr. Lockwood is a second-year fellow in rheumatology at Mass General Hospital. Her clinical and research interests include bone health, connective tissue diseases, health disparities, and medical education. She is here today to give a presentation on bone health, so please join me in welcoming Dr. Lockwood.
All right. Hi, everybody. Good afternoon and good morning to some of the West Coasters on here. It's really wonderful to see so many familiar names and get to talk about bone health. I think our presentation today, we're scheduled for noon to 1 East Coast time. The presentation should be about 40 to 45 minutes, and then we'll have 15 to 20 minutes for questions at the end. Please feel free to put any questions in the chat box, and either Amy and then Dr. Bolster will be joining us in a bit, is welcome to kind of interrupt me and we can pause and chat a little bit. So let me get my slides pulled up and then we will get started. All right, can everybody see my slides? Great. So the title of the talk today is Osteoporosis, Are Your Bones Strong? My name is Megan Lockwood. I'm a rheumatology fellow at Mass General Hospital, and we'll be joined shortly by Dr. Marcy Bolster, who's our fellowship training director and associate professor of medicine at Harvard Medical School, who has joint appointments both in the Division of Rheumatology as well as the Division of Endocrinology, focusing on bone health. So today here, this is just a roadmap for what I'll be talking about. We'll talk about what is osteoporosis. Can I be screened for osteoporosis? How is osteoporosis treated? And how can I reduce my risk of osteoporosis and its complications? So what is osteoporosis? Osteoporosis is a word that's used fairly often, but not always fully understood. It is a bone disorder that affects the entire skeleton. So it is a disease. It is not just a natural part of getting older that causes your bones to lose mass or bone density. And when your bones lose mass and density, they become more weak and then are more likely to fracture. Most osteoporotic fractures occur in the spine, the hip, and the wrist. And you probably hear about hip fractures a lot, but it's actually spinal fractures that are the most common fracture type. And these can lead to significant disability and deformity. And we'll talk about that in a bit. Just to give you a bit of a visual idea, here on the left side of the screen, if you can see my pointer, this is what healthy bone should look like. Moving to the middle, in patients that have osteoporosis, you can see that the bone here is becoming weaker. The bone itself is the white part, there's less mass. And when you have severe osteoporosis, your bones become very weak and porous. And you can imagine how a bone like this here on the right can break much easier than a healthy bone like this here on the left. So why do we even care about osteoporosis? It is incredibly common. 44 million Americans have either osteoporosis or low bone mineral density. 10 million Americans have osteoporosis, and 30% of postmenopausal women have osteoporosis. It's very serious. Osteoporotic fractures lead to disability and death. It's actually very easy to diagnose, and we're going to talk a lot about bone density testing today, and it can actually detect osteoporosis before a fracture even occurs. We also have a lot of really good treatments available, and when we treat osteoporosis, it can reduce your risk of fracture by 50 to 70%. And in this picture here, this is a bone model of osteoporosis. And here on the right, this is an osteoporotic bone. You can see a really deteriorated architecture of the bone, decreased bone mass. It's very porous. And here on the left, this is that same bone after treatment. So treatment can be very effective. So what is the impact of osteoporosis? Postmenopausal osteoporosis is a major health issue in the United States. As I said earlier, 10 million Americans have osteoporosis, and another 34 million Americans are at high risk for developing the disease. 40% of women over the age of 50 are at risk for developing an osteoporosis-related fracture in their lifetime. And I think many find it surprising that each year, the risk of suffering from a fracture related to osteoporosis is greater than the combined risk of having either a heart attack, a stroke, or breast cancer. So it's a very big deal. It's very important for postmenopausal women. When we talk about fractures caused by osteoporosis, we usually use the term a fragility fracture, which is one of the most serious consequences of osteoporosis. So what is a fragility fracture? Well, there are many different types of fractures. And when you're younger, maybe your child breaks their arm, you think of things like a traumatic fracture. And a traumatic fracture is one that occurs because there's a force exerted on a bone. So when your child twists and falls ice skating, or there's a car accident, or you fall from a ladder. That's not what we're talking about here. A fragility fracture is a fracture that occurs when a bone fractures from the result of a normal force that wouldn't otherwise be required to break a bone. So it's when you have a fall and you shouldn't fracture from it. So for example, on the slide here, you see a 21-year-old woman on her left walking through the snow and the ice, like is so common here in Boston, and she trips and falls. It's no big deal. She gets right up. On the right, we see that same situation, but a 60-year-old woman with osteoporosis. This woman is much more likely to fall and fracture either her hip, her spine, or her wrist. This is what we refer to as a fragility fracture. And we're going to talk about this in a lot more detail. What's so important to know is that 2/3 of fragility fractures are painless. But these fractures can lead to disability, decreased quality of life, and increased mortality. And what increased mortality means is death. There's a 20 to 25 increase in mortality or death as early as 1 year after a hip fracture, and 5 to 8 times increased risk in the first 3 months of a fragility fracture. Falls lead to fractures. 1 in 5 patients with a fragility fracture is going to have another fracture in the next 5 years. Half of patients with a hip fracture have already had another fragility fracture, whether they knew it or not. 1 in 10 patients with a hip fracture are going to fracture their hip again in the next 5 years. So let's talk a little bit more about a hip fracture. This picture here on the right is an X-ray that shows a fracture of the hip. So this is your hip, but this is your pelvis here. This is your femur. This is your hip joint here. And this is where the bone is broken. Hip fractures are one of the most severe fragility fractures, especially when the fall occurs sideways directly onto the hip. These fractures often occur just from a fall from standing position. These are very painful fractures and almost always require hospitalization. Nearly all hip fractures require surgical intervention, either total hip replacement or pinning to stabilize the fracture. The mortality rate, which means the rate of death following a hip fracture, is very high. It's 20 to 40% in the first year. And when someone sustains a hip fracture, it's often that event that sets in motion just a cascade of frailty and worsening of other underlying conditions that can ultimately result in death. The mortality relates not just to the hip fracture itself, but also complications of being less mobile, such as developing blood clots in your legs, blood clots in your lungs, or pneumonia. Let's talk about spine fractures a little bit. Here on the right, this is an MRI of a spine. This is the lumbar spine, so the lower back, and then this is the sacrum here. These big white things here are your bones, and in between are your discs. And you can see there should be a bone right here, and it's completely crushed. It's compressed. That's what we call a vertebral compression fracture. The spine is made up of vertebra. Those are the backbones. And those are especially vulnerable to osteoporotic fractures. So compression fractures like seen here on this MRI typically result from just a twisting motion of the spine. You reach to grab something and all of a sudden you feel a terrible pain in your back. It can occur when you're bending or lifting, but sometimes in patients with osteoporosis, it can occur just from a cough or a sneeze. When this happens, people often experience a sudden onset of pain, but it can also be entirely silent and just found by accident when you got an X-ray or an MRI for an entirely different reason. If these are left untreated, people with these vertebral compression fractures are at high risk of developing additional compression fractures, which can then lead to curvature of the upper back. So that kind of hump, we call that a dowager's hump. And that change in appearance, well, for one, it can really contribute to low self-esteem. But that curvature of the spine can also cause compression of your abdominal organs. When you have increased pressure on the stomach, it can lead to a feeling of fullness, even after only just a small amount of food, and that can lead to malnutrition. It can also prevent your lungs from fully expanding, which can cause difficulty with breathing and with sleep, which can lead to a whole other cascade of negative health events. Then as with hip fractures, spinal fractures are associated with both functional decline and decreased mortality. And I wanted to share this image with you on the here. On the left, we see a completely normal spine, and you see kind of the normal vertebra up here. And on the right, this might be a familiar picture to a lot of people. This is an osteoporotic spine. This is that same person. You see all of a sudden they're shorter because they're losing height from their compression fractures. Their spine is bending in several ways, and you can see how it might compress your abdominal organs, your belly organs, how it could make breathing a little bit more difficult if you're not able to sit up straight. This is, I think, when we think of older, frail women, this is often a picture that I think comes to mind, and oftentimes it's due to osteoporotic compression fractures of the spine. Wrist fractures are also common in osteoporosis, and wrist fractures typically occur after a fall on an outstretched hand. You can imagine if you're walking in the ice or the snow and you push your hand out if you're falling, that's a very easy place to fracture. It usually occurs at the end of the radius, and that's one of the two long bones in the forearm that expands from the elbow to the thumb side of the wrist. These fractures are actually usually cause pain and stiffness, but don't tend to affect mobility. And as a result, we don't think that they are associated with any increased mortality. Just briefly, osteoporosis and fragility fractures are associated with a significant cost to the healthcare system and to society. Fragility fractures pose a huge economic burden, and according to a report by the Surgeon General in the early 2000s, osteoporosis-related fractures are associated with over 400,000 hospital admissions, 2.5 million office visits, and 180,000 nursing home admissions every year. In the United States, treatment costs of fragility fractures in 2003 was $17 billion. That is 17 times the cost of those cared for with congestive heart failure. By the year 2025, these costs are expected to increase significantly and predicted to be in excess of $25 billion per year. So can I be screened for osteoporosis? I think my grandmother is here today, and Grandma, this picture is for you. Bone fractures occur, and osteoporosis is a silent disease before bone fractures occur. As we age, our bone loss occurs quietly and painlessly, and people are often symptom-free and unaware that their bones are weakening until they have a fragility fracture. After a fracture occurs, symptoms include pain at the fracture site, decreased height and curvature of the spine. But even after a spine fracture, people still might not have any symptoms. And surprisingly, like I mentioned earlier, 2/3 of spinal fractures are actually painless. This silent nature of osteoporosis is similar to what we see in other diseases. So, for example, in atherosclerosis, plaque develops in your blood vessels and there are usually no symptoms until the blood vessel is completely blocked and the person experiences a heart attack. High blood pressure is usually discovered by measuring your blood pressure at the doctor's office, not because you're having symptoms, but it's incredibly important to treat to reduce your risk of stroke or heart attack. Osteoporosis is the same thing. So that begs the question of who should be screened for osteoporosis. So according to our national guidelines, you should be screened, and typically that's with a DEXA scan, which we'll talk about in more detail. All women 65 years of older, a woman with a history of any fragility fracture, because that's really a key risk. If you are post-menopause with at least one other risk factor, so things like fractures, if you take steroids, if your mother's had a fracture, low body weight, active tobacco use, excess alcohol, rheumatoid arthritis, or some other diseases that can cause secondary osteoporosis. Or if you're any adult that has a disease or medication history that's associated with bone loss. And there are a lot of medications that are associated with bone loss. Some of those include prednisone, breast cancer medications, seizure medications, and certain types of birth control. You know, a common question that we get asked is, what are the recommendations for men? And the recommendations for men are a bit more variable. In general, DEXA screening is recommended for men aged 70 and older. Osteoporosis really is not just a disease of women. It does affect men as well. But we don't have a great accurate estimate of the number of men who are affected by osteoporosis, often because they're not screened very often. But we do know that about 50% of Caucasian women and 20% of Caucasian men will develop a fragility fracture related to osteoporosis in their lifetime. So what factors increase your risk for osteoporosis? When we talk about risk factors, we think of things that are modifiable and not modifiable. The things that are non-modifiable are the things that you just can't change. So those are things like age, gender, race, if anybody in your family has had a history of fragility fractures, early menopause, a very slender build, and certain medical conditions. Gender plays a really important role in the development of osteoporosis, and there's a much higher rate of this condition in women. People from certain ethnic backgrounds have a higher risk for developing osteoporosis. Caucasians and Southeast Asians are more likely to develop osteoporosis. Your risk also really increases with age, and that's partly due to changes in your bone architecture over time, and partly due to changes in hormonal levels. Alterations in hormone levels with aging, such as lower sex hormones in women after menopause, leads to higher rates of osteoporosis, and then a higher chance of developing a fragility fracture. Women who had early menopause, either due to ovarian failure or removal of their ovaries, often develop osteoporosis at younger ages. If you have a family history of osteoporosis or you are at a genetic predisposition, if your parents had a fragility fracture, that puts you at an increased risk. And there are several other medical conditions that can increase to your risk as well, including inflammatory arthritis, like rheumatoid arthritis, chronic obstructive pulmonary disease or emphysema, diabetes, thyroid disease, and celiac disease. So these are things about yourself that you really can't change. That's why we say non-modifiable. So what are the modifiable risk factors? These are lifestyle factors that you can change. And there are many lifestyle factors that are associated with osteoporosis. Smoking cigarettes and being exposed to secondhand smoke has significant adverse effects on bone health. Drinking excessive amounts of alcohol, usually 3 or more drinks a day, can increase your risk. Taking inadequate amounts of calcium and vitamin D is associated with the development of osteoporosis. And this is because calcium and vitamin D both play a very important role in maintaining bone structure. And as I mentioned briefly before, there are certain medications that increase your risk, most notably steroids and other breast cancer medications. So the most common screening tool for osteoporosis is something called dual energy X-ray absorptiometry, or what we call DEXA scan. And this is a test that uses X-ray technology to assess the density of your bones. It can measure at the hip and the spine, and then it compares that to bone density to that of a young, healthy adult. And the resulting comparison, the number that you get, is called the T-score. And I'm going to be coming back to that a lot. So measurements of bone mineral density are typically performed at both the spine and the hip because these areas have been shown to be the best predictors of future fractures. We like to measure it at least 2 sites because measurements provide different information. Bone loss usually occurs first at the spine, so those lumbar spinal scores are really helpful to diagnose osteoporosis as early as possible. You might also hear about other tests, such as peripheral screening tests, such as at the ankle, the hand, or the finger. And these are often used as screening tests to indicate possible risk of fracture, and they're sometimes used when a DEXA scan isn't available, but these are not as accurate, and these are not part of the definition of osteoporosis. So these peripheral tests are not used to make or confirm a diagnosis of osteoporosis. I imagine many of you have had a DEXA scan or your physician has started to talk about it with you. And this is what a DEXA scanner looks like. So this is a test that takes less than 20 minutes. It's safe and painless X-ray technique. And like I said, it compares your bone density to the peak bone density of someone your same sex and ethnicity at about age 25 when it's at its highest. It's non-invasive, so it doesn't go through your skin. It causes no pain, and there's very low levels of radiation, less than what you would even get with a chest X-ray. And it analyzes your bone loss, predicts your chances of breaking a bone, and confirms that you have osteoporosis after a fracture and whether or not your treatment for osteoporosis has been effective. So this kind of brings the question, how do we diagnose osteoporosis? And there are 2 ways to diagnose osteoporosis. It can be diagnosed clinically or it can be diagnosed radiographically. If you have ever had a fragility fracture, then you have osteoporosis by definition, regardless of what your bone mineral density is. That is diagnostic of osteoporosis and merits treatment. If you have not had a fragility fracture, then we look at your DEXA scan, and that's what we call the radiographic diagnosis. DEXA scans have been proven to be accurate screening tests for osteoporosis, and studies have shown that the decrease in bone increases the risk of fracture. The decrease in bone mineral density increases the risk of fracture. The World Health Organization defines osteoporosis as a T-score of less than or equal minus 2.5. And remember that T-score is the score that's comparing your bone density to that of a young, healthy, age and gender matched control. So when you get a DEXA scan, your doctor is going to be looking at 3 important scores. We're going to be looking at the T-score, the Z-score, and your bone mineral density, or BMD. Briefly, the T-score, like I said, is going to be comparing your bone mass to a young, healthy adult. The Z-score is comparing your bone density to that of someone who's the same age and gender as you. So we use this score for premenopausal women or younger men. Otherwise, we don't use that score as much. And then you get the BMD, the bone mineral density score. And this is a really helpful score to compare your bone mineral density over time because we get these tests every 2 years or so. And we want to see what's happening over time and also how is your body responding to treatment. So the T-score is clinically the most relevant value on the DEXA report. And like I said, the World Health Organization has definitions of osteoporosis based on your T-score. So a normal T-score, normal bone health, is considered to be greater than or equal to -1. When someone has osteopenia, which we're going to talk about in a little bit, that is when their Z-score is from in between -1.1 and -2.5. Osteoporosis is defined as a T-score less than or equal to -2.5. So the take home for you, the important thing to remember, the lower the T-score, the higher the risk of fracture. I just want to point out that the association between your low bone density and fracture is actually a stronger association than your blood pressure and stroke, or between cholesterol and heart attacks. This is a very important correlation. And I just want to show you this graph here. What we're seeing here on the left-hand side is the risk of fracture, and on the bottom side is the T-score. And again, what this is showing to you, for every decline in the T-score by 1, there's a doubling of the fracture risk. So this is really an exponential relationship, not a linear relationship. So I'm going to shift for a moment and talk about osteopenia, which is probably a term you've heard a lot. And this is very common. About 50% of postmenopausal women, so over the age of 50 who fracture, have osteopenia. That means their T-score was between -1 and -2.5. So remember, -2.5 or lower is osteoporosis. So it's somewhere between normal and osteoporosis. So what do you do with those patients? What does that mean? That's when your what do we know about the risk of fracture in patients with osteopenia? It's a really important question that we think about a lot. And that's when your doctor will use something called the Fract Score. The Fract Score is the fracture risk assessment tool. And we use this because a DEXA scan really does not capture all aspects of bone strength and fracture risk. And it's really important that we think about other risk factors. So your doctor, we'd use this in the office all the time. This is just a risk calculator, and it takes into account your individual risk factors for developing an osteoporotic fracture. So it's going to tally your risk or probability for developing a fracture in the next 10 years. It takes into account your age, your weight, if you've had any prior fractures, if you take steroids, if your parent has ever had a fracture, if you have rheumatoid arthritis, if you currently smoke, and if you have heavy alcohol intake. This is what we use to determine who are those highest risk patients with osteopenia that would benefit from treatment. So this Fract calculator, it calculates your 10-year risk of developing a fracture, either any osteoporotic fracture, and then also your hip fracture. And these are the scores that we're looking at. And if I have a patient, or if we have a patient that has a 10-year osteoporotic fracture risk of greater than or equal to 20%, then we recommend treatment for osteoporosis. If you have a 10-year hip fracture risk of greater than or equal to 3%, then you are a high-risk patient, and we recommend treatment for osteoporosis. So that gets us to, how is osteoporosis treated? And this is kind of our pyramid of treatment. And the most important thing at the bottom is fall prevention. So we're going to talk about that. We want to talk about lifestyle interventions such as modification of risk factors, fall prevention, weight-bearing exercise. Those are really the foundation of good bone health. Prescription medications are here at the very top, and they're only used when absolutely necessary. So let's talk about fall prevention. Avoiding falls is really the highest priority and the most obvious way to avoid a fracture. Your doctor might actually recommend an occupational therapy assessment where a therapist can actually improve how you do your activities of daily living. They can do a home visit and screen for fall risk hazards such as loose throw rugs, and make suggestions on how to make your day-to-day tasks easier to perform. These are some things that you can do around your house to reduce your risk of fall. Place frequently used items within reach so that you don't need to bend forward. If you live alone, consider wearing a personal emergency response device or carry your phone with you so that you can call for help if you fall. Keep your floors free of clutter. Remove all loose cords, things that are easy to trip on. In general, avoid throw rugs, or at least make sure your rugs have kind of skid-proof backing or are really well secured on the floor. In the bathroom, you may need handlebars on the bathroom walls besides the tub, the shower, and the toilet. Again, in the shower and the tub, using those non-skid rubber mats or stickers can be really helpful. If you feel unsteady on your feet, having a plastic chair in the tub or shower can be helpful. And then adding height to your toilet seat can actually help to be able to sit down and improve both mobility and comfort. We also recommend using handrails if you need to climb more than 2 to 3 stairs at a time. And if you are really unsteady on your feet, put handrails on both sides of the stairs. In the bedroom, put a night switch or a night light between your bed and the bathroom. We don't want you walking in the dark and tripping over something in the middle of the night to go to the toilet. Avoid slip-on shoes that can really easily fall off your feet, slide out from your feet, and lead to tripping. And consider house slippers that actually cover the back of your feet and are not slip-on. So we talked about fall prevention a bit. There are other lifestyle modifications such as weight-bearing exercise that can be really helpful, as well as a diet that I'm going to talk about now. Let's focus on that. You probably hear a lot about calcium and vitamin D. Calcium is a primary mineral and for your skeleton and ensures that a normal calcium balance in your body is needed so that your skeleton is fully mineralized and strong. Vitamin D is also really important for your bone health because it helps your body to actually absorb the calcium from your GI tract, your gastrointestinal tract. And studies have looked at whether calcium and vitamin D alone are sufficient to decrease your risk of fractures, and the results are really mixed. But most osteoporosis experts recommend maintaining a minimum amount of calcium and vitamin D for your bone health. Oftentimes, this is not enough, and so your doctor might also recommend a prescription medication, which we'll talk about shortly. A question I get asked a lot is how much calcium is enough. If you've been diagnosed with osteoporosis, expert guidelines recommend taking between 1,000 and 1,200 milligrams of calcium daily. This can be met through dietary sources, pills, or both. So for example, you might take one 600 milligram tablet of calcium a day and then have 2 servings of dairy each day to meet your goal of 1,200 milligrams. We really want you to get as much from your diet as possible. Calcium is found in a lot more than just dairy. So I wanted to give you, as you can see here from this photo, fish, beans, leafy green vegetables are all excellent sources of calcium. Other sources are milk, yogurt, cottage cheese, things like sardines, kale, broccoli. So really, there are a lot of different ways you can get calcium in your diet. The most common form of calcium supplements are calcium carbonate and calcium citrate. They're both excellent choices and either one is fine, but if you take a medicine for heartburn called a proton pump inhibitor, then you should probably choose calcium citrate. And the reason for that is calcium carbonate actually needs the acid in your stomach to be absorbed. So if you're taking a medicine to remove all of that acid, your body's not going to absorb it. So then citrate's a good option. It's also important to note that if you take calcium pills, you really need to separate your calcium servings throughout the day. It turns out that your body can only absorb about 500 milligrams of calcium at a time. So it's really important that you separate your pills and your servings of calcium throughout the day and not just have 3 or 5 big glasses of milk in the morning. So for vitamin D, most experts recommend between 600 and 800 international units of vitamin D daily. If you have a low vitamin D level in your blood, you might need a higher dose. There's not many food in the typical American diet that actually has an appropriate amount of vitamin D. So supplements are really the main source for that. Your body can actually make vitamin D when you've been exposed to the sun, but we typically don't recommend this strategy because sunscreen actually blocks vitamin D absorption, and going outside without sunscreen can cause a whole bunch of other problems, including skin cancer. You can get vitamin D supplements over the counter, or your doctor can prescribe them for you if needed. I wanted to have a quick note about exercise. One major way to keep your bone healthy is to exercise. It is imperative that the exercise is weight bearing. So that's exercises like tennis, like walking or running, like hiking or Tai Chi. Exercises like swimming or water aerobics, cycling, those are non-weight bearing exercises. And while they're good for your cardiovascular health, they don't help to build strong bones. Exercise is important both in terms of prevention and treatment for osteoporosis. And there's so many benefits of exercise. It decreases your risk of falling, it increases your bone mass, enhances your muscular strength, increases your balance, flexibility, overall fitness, and actually improves depression. So now I'd like to shift gears and I want to focus on medications. I think there are so many questions that come up with patients about this. I want to make sure we have lots of time to be able to discuss this. There are several prescription medications available for the treatment of osteoporosis that we're going to review together. Broadly, these can be organized into two categories. We have anti-resorptive agents and anabolic agents. And it's important to understand how these medications work. And it's important to remember that your skeleton is always actively building up and breaking down. Anti-resorptive agents help to slow the breakdown of bone. Anabolic agents help to increase bone formation. They both ultimately increase your bone mass. So here, this is a busy slide. These are just the major anti-resorptive agents. We'll talk about them in more depth quickly. Briefly, of the oral bisphosphonates here, Fosamax, Beniva, Aconel, alendronate, abandronate, resendronate. These are usually tablets taken by mouth, either weekly or monthly. We can also give the medication through intravenous. So you get a catheter put into your arm and you get it, so we call that an IV infusion. Most of those can be given either every 3 months or every 12 months. This medication here that works a little differently, denosumab, that's actually an injection you get every 6 months. And then finally here, raloxifene is a daily tablet. So as you can see here, this is just to give an overview that there's a lot of variety in the medicines we have, how it's given and how often you take it. And then there's the anabolic agents that build your bone up. Just briefly, teriparatide and abaloparatide, these are daily injections. And then briefly, romosozumab is a monthly injection. I want to talk a little bit about bisphosphonates, which are the first line treatment for osteoporosis. So these are medicines like Fosamax or Reclast. You've probably heard a lot about them. Oral bisphosphonates, so that's Fosamax or alendronate or similar medicines, have been extensively studied and we have extensive safety data on these medications since they were first approved by the FDA in the 1990s. These can increase your bone density and have been shown to reduce the risk of spine and hip fractures. This medicine can be prescribed as a pill, like I said, taken either once a week or once a month, or as an intravenous infusion. Even though all medicines have side effects, not all side effects develop in all people. And in considering what would be acceptable to you, it's really helpful to keep in mind the frequency of the side effects that vary and how they vary. And it's important for you to be aware that of the most serious side effects, they tend to be very, very rare and very uncommon. The most common side effects for the oral bisphosphonates, so medicine like Fosamax, tend to be gastrointestinal symptoms, so like heartburn, belly pain, nausea, or esophageal discomfort. If you have pre-existing heartburn, then we usually recommend the IV version of this medicine instead of the tablet version. To increase absorption of this medicine and decrease these side effects, we recommend you take these pills on an empty stomach with a full glass of water. You don't take it with any other pills or food, and then you remain upright, either sitting or standing, for at least 30 minutes to prevent the pill from refluxing and causing heartburn or irritation. For the most common side effect of the IV version of these medicines, so Reclast or zoledronic acid, is this flu-like reaction. It typically starts in the evening of the infusion or the following day, and it can last for several days. About a third of patients report feeling tired, achy, or having low-grade fevers. It's really important on these days when you get your infusion to stay really well hydrated. And I just want to make a note, this is not an allergic reaction. It's a very, and a way that this can be reduced is to actually take Tylenol the morning of your infusion and then to take Tylenol when you get home about 6 hours later. It occurs in up to a third of people and it is not an allergy. Most people who experience this flu-like reaction the first time actually report that it's much less severe or doesn't happen at all with subsequent doses. One of the more very rare but very serious side effects is something called osteonecrosis of the jaw. And we see this with a lot of our anti-resorptive medications, bisphosphonates and denosumab. And this is it's a very rare condition, and it is a condition of delayed healing of the jawbone. It's almost always seen in the setting of invasive dental work when your jawbone is exposed. So that's like having an implant or getting an extraction. Superficial dental work, such as root canals or crowns, are much less likely to cause these problems at all. And we actually do recommend that you get dental cleanings twice a year to really prevent the need for any unexpected dental work. And if you do require more invasive dental care, then you and your doctor can really work together to time the medicine and the procedure. This side effect is much more often seen in patients when they get these medicines as a part of their cancer treatment, because they're getting them at higher doses at higher frequencies. Those are not the doses or frequencies that we use in osteoporosis. So this is very uncommon in patients with osteoporosis. Another serious but important side effect to be aware of is something called an atypical femoral fracture. And this is another very uncommon complication of chronic bisphosphonate therapy. The risk for this type of fracture, and this is a break in the thigh bone that can occur with really little or no trauma. And it usually increases the longer you're on this medication, especially usually in patients beyond 5 years. This is something that really, the symptoms of this evolve over time, and patients who've been on these medicines for a long time will often feel a dullness or an achiness in the groin or the thigh. But this raises a really important question. How long should you be on these medications? And that's what I want to talk about next. We think very importantly about this concept of a drug holiday. We don't recommend that you stay on these medications forever. And that's because many people are going to experience side effects the longer that they're on these medications. So this idea of a drug holiday, that's when you intentionally stop taking your medication. And the effect of osteoporosis medications, some of them wear off really quickly, but some of them last for a really long time, for months or even years. So by taking a holiday from the medicines, your bones can get a little bit of a break. They can be relieved from these longer term side effects, but you can still get the benefits of the treatment. It's hard to know exactly when the medication will wear off for each patient. So typically we repeat your DEXA scan every 1 to 2 years after we stop the treatment to figure out the ideal time to restart it and to minimize those risks. When you're taking a drug holiday, your bony turnover, your bony breakdown can resume. So we always need to monitor you for ongoing bone loss. It's important that you continue fracture risk prevention, like reducing falls and continuing calcium and vitamin D intake. We take a lot of factors into consideration when we're thinking about a drug holiday, including your age, your risk factors, and if you are ever to develop any new fracture. The bottom line is this is really an individual decision with each patient, and as your physicians, we're thinking about this very regularly. Really, I think an important take home for you is that when you're deciding what medications to take, it's really important to weigh the risks and the benefits. And for nearly all people with osteoporosis, the likelihood of a fracture from your weak bones is very high. And the benefits of the medicine most often very far outweigh the risks of the medicine, but it's a very individual decision. I just have a very few slides left, and I just wanted to quickly address how can you reduce your risk of osteoporosis and complications. And in medicine, we talk about the concepts of primary prevention and secondary prevention. Primary prevention is preventing a fracture before it occurs. Secondary prevention is reducing the risk of your fracture after it occurs. So primary prevention, that's what I'm wanting to do. For those of you that have not had a fracture, we want to prevent you from fracturing. So we want to make sure you're getting your screening test, your risk is being appropriately assessed. If you have osteopenia, then we're using the Fract calculator to see if you're at a higher risk of fracture. We're modifying your risk factors, your risks for falls, and then we're thinking about treatments, and we're making sure that you're getting the right drug, you're taking it the right way, and we know how long you're going to take it. If you have a fracture, we continue your medications. We want to reduce the impact of the fracture after it occurs and prevent another one from happening. The medications and treatments we have don't cure osteoporosis, but they reduce your fracture risk and increase your chance, your living. They decrease your mortality, so you live longer. And we want to continue those medications because, as we talked about at the beginning, the fracture risk is so high once you've had one. So we want to do everything we can to reduce the next one. And finally, I just want to leave you with this concept of the osteoporosis challenge. And this is something myself and Dr. Bolster and all of us here at Mass General and rheumatology and endocrinology think about. We want to make sure that we educate all patients on measures to maintain good bone health. We want to identify those patients at high risk for osteoporosis. We want to use screening tests to detect low bone density before a fracture occurs. We want to make sure that we educate our patients about treatment options and that patients are able to consider the risks and the benefits. We want to use not just risk factor reduction, medications, and exercise, a holistic approach to treating osteoporosis and bone health. And we always want to be thinking about how long you should be on these medications. Finally, I've given you a lot of information. We'll have plenty of time for questions. I'll be available to chat. There are several great resources, including the National Osteoporosis Foundation, American Bone Health, and the International Osteoporosis Foundation, where you can find more information. They have great patient-centered websites and videos. And lastly, we have a book here at the Mass General that Dr. Bolster edited called Facing Osteoporosis, a guide for patients and their families, which is a wonderful resource for patients that are living with and battling osteoporosis. So thank you so much for your time and attention. And I'm going to go ahead and stop sharing my screen. And I would love any questions or comments anybody may have.
Great, thank you so much, Dr. Lockwood. We have some questions that are coming in.
And I'd love to actually introduce Dr. Bolster since she joined us. Or maybe Dr. Bolster could introduce yourself.
Yes, I'd love to. You can hear that I have a dog with a loud bark in the background. Perfect timing, Charlie. I'm Marcy Bolster, and I'm one of the rheumatologists at Mass General Hospital. And Megan is one of the rheumatology fellows working with me. And I'm the director for the Rheumatology Fellowship Program. And I also see patients in the endocrine clinic for osteoporosis. And I just would like to thank Megan for such a spectacular presentation. It was very informative, and I think really hit on a lot of the high points, though we know there are lots of questions that exist about osteoporosis. And there are several questions that I've seen in the chat. So I'll go ahead and start asking Megan those questions, and then please feel free to add others. So one of the first questions that came in was, think about bone health from even the time of adolescence. And is there a role for trying to promote good bone health in adolescence, including thoughts about exercise, diet, even stress management?
That's a great question. I think in general, lifestyle measures are so important. Weight-bearing exercise is really important for everybody to help with increasing your bone mineral density and ensuring that when your bones are growing, you're getting enough calcium to support bone growth. Dr. Bolster, do you have anything to add to that in terms of management and risk factors in adolescence?
Well, I think what you said is exactly right, that it's an important time we're trying to get to peak bone mass by the age of 30. So ensuring that there's adequate intake of calcium and vitamin D in childhood, adolescence, and even in the 20s. And that can be a tougher time for people to ensure adequate calcium. The other thing, though, is that weight-bearing exercise, as we know, is helpful in osteoporosis. But in terms of building and establishing healthy bone, there are studies looking at exercise that has to do with start and stop and jumping, and the kind of the soccer or where you have the quick start and stops, or tennis. And that can be really effective in helping to establish healthy bone and building towards a good level for what's considered normal or peak bone mass. And I don't know about stress management. That came up, and I think stress management is good at any age, but I don't know its specific effects on bone. There's a question that relates to calcium. I think you answered the questions ahead of the questions were asked about calcium and vitamin D, and I think those were answered in the talk. But if any of the attendees feel like you'd like to hear more about that, please submit another question. There was a question about milk and calcium content, and is there a difference between skim and regular milk?
Actually, I don't think there is. I'm not aware that there is.
No, I don't think so.
Soy and almond milk actually have a significant amount of calcium, usually the same as whole milk or even a little bit more when it's fortified.
Yes, I agree. Yeah, I don't think there's a difference. I think the difference between skim and regular would just be the fat content. And then could you comment on having the subsequent DEXA scans performed, and do they need to be performed at the same facility?
That is such an important question and a really important point. It is, when you're comparing DEXA scans, again, we're comparing the bone mineral density. So those are the scores that we're looking at. How have your bones gotten stronger or weaker over time? And every DEXA scanner, for whatever reason, is a little finicky. And so it is actually important you get it done on the same machine every time. And in fact, when we calculate your Fract Score, we actually put in the brand of the machine, because every machine does them a little bit differently. So once you get it done on one, do it on that same one, if you can.
Yep, I agree. And then there's a question about, for women over 50, if there's no known family medical history, when should we start conversations with our providers?
That's great. I would encourage you to start a conversation with your provider at any age. And I think when you're 50, especially in that postmenopausal time, and so many things are changing and your health is changing so much. But I think it's also important to talk with your physician about what other risk factors you might have for osteoporosis. Without any risk factors, we recommend screening with a DEXA starting at age 65. But if you have other risk factors from certain medications, certain illnesses, family history, I think starting to talk about bone health as early as possible is really important.
Great. And then are there foods that block calcium absorption?
Oh, good question. I know that there's medications that can block calcium absorption. I'm not sure if there are any particular foods that block it. Dr. Bolster, are you aware of any?
I'm not either, actually.
Yeah.
I do want to comment. I noticed your picture on the dietary calcium content of foods, and I agree. I think it's ideal to try to get as much calcium through diet and minimize the number of supplements that we need to take. And many people find that they can easily get half of what they need through diet and then take one tablet a day. I wanted to make a note because you had this beautiful picture of fish there, and it's actually canned fish rather than wild or Atlantic salmon. The canned fish contains bones that are edible, and it's the bones in the fish that have the calcium content. So just to clarify that. There was a question about, you mentioned when you were talking about the mortality associated with hip fractures or morbidity, the loss of active lifestyle and the increased mortality associated with hip fractures in particular. You mentioned that pneumonias can happen, and the question came up as to why would somebody who's in the hospital get pneumonia?
Oh, that's such a great question. It is hospital-acquired infections, just in general, are so important to recognize. The longer a patient is in the hospital for any reason, they have a higher risk of developing an infection. And that can be a urinary tract infection, that can be pneumonia, etc. For patient, pneumonia in particular can be very devastating illness to have. I think for patients with hip fractures in general, you're not you're not moving around very much. And when you're immobile, your lungs can't open up the same way, which is so important. But also, if you're in the hospital for a long time, you just have a higher risk of getting an infection, and pneumonia at an older age can be very devastating.
Thank you. And Dr. Lockwood, are there, can you comment on there's a question related to degenerative disease in the spine and risk for fragility fractures. Is there a relationship?
Oh, that's an interesting question. So when I hear degenerative disease in the spine, I believe that as the rheumatologist, I'm thinking of that referring to osteoarthritis, which is separate and a completely different process from osteoporosis. So osteoarthritis is, degeneration of the joints, and osteoporosis is weakening of the bones themselves. That being said, osteoarthritis and osteoporosis commonly coexist. Dr. Bolster, would you have anything to add to that?
No, I think that it's a common area of confusion. They sound like osteoarthritis, osteoporosis. I don't think that, and I'm not sure if the question specifically related to, I don't think that having degenerative disease in the spine increases your risk for a fragility fracture. It's just two separate conditions that can affect the spine. And the patient could actually have both. And then there's a question about caffeine. And can you comment, is it bad to have too much caffeine in terms of your bone health? And then do you have any recommendations in terms of milligrams of caffeine?
That's a great question. And as an avid coffee drinker, it's a disappointing answer. But my understanding is that caffeine is likely a risk factor for osteoporosis. My understanding is, and Dr. Bolster, I'd love to hear your thoughts about this, is that at a lower level, it tends to be okay, but at a higher level, it can actually both decrease your bone mineral density, but also can impact your ability to retain calcium.
Yeah, I think there are a lot of uncertainties. It's thought that high levels of caffeine may have a negative impact on bone health, but I know the question was how many milligrams, and I wish we could provide that. I don't know that. I don't know that anybody knows that.
I don't think so.
Dr. Lockwood, that was fantastic. I think that's all the questions in the chat. I don't know if you have any kind of parting comments, but I will tell you that the chat has been very complimentary, and that people have really enjoyed this and have found it very informative. So I don't know if you have anything else to add as we're closing.
I think I would just close by, reiterating that osteoporosis is such an important consideration for postmenopausal women in particular. It's incredibly common, and it's a silent disease. Many of us, if we don't have it already, we will develop it. It's important to talk about for your physicians, and I encourage you to advocate for yourself and ask these important questions to your physician. And as always, if you have more questions, absolutely see an endocrinologist, see a rheumatologist. We're happy to discuss these things. Your bone health is incredibly important for your quality of life, and we want to do everything we can to prevent a fracture from occurring so you can live your longest, healthiest, and happiest life.
Great. Thank you. And thank you, Amy, for inviting us to talk.
Yeah, thanks so much, Amy. Thanks everybody for joining. Appreciate your time.
And again, if anyone wants to view the recording of today's session, it will be made available on Blum's website at massgeneral.org/Blum-Center. Again, thank you so much, everyone, for joining us today. It was very helpful.
Okay, great. Thanks. Bye.